Hello, thank you for joining NCCN's patient webinar, Small Cell Lung Cancer. My name is Tanya Fisher, and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 33 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines from patients from the NCCN website. High quality printed copies of the book can be purchased through Amazon. And if you ordered a free book when you registered for this webinar, you should be receiving it shortly. The NCCN patient webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Rafael Santana de Villa. Dr. Santana de Villa is Associate Professor at Fred Hutchinson Cancer Center. Following Dr. Santana de Villa, we will hear from Katie Johnson. Katie is a clinical nurse coordinator in the Thoracic Head and Neck Department at Fred Hutchinson Cancer Center. And our third presenter today is Charles Forsheim, patient advocate. Now I will turn it over to Dr. Santana de Villa.
Hello. Hi. Thank you for that introduction. I just want to make sure that you guys can hear me okay. Good. So I work very closely with Katie here. We are part of the thoracic clinic at the Fred Hutch in Seattle, and today we're going to talk about small cells. So let me see. Yes, so that is the introductory slide. This is my disclosures. What is small cell? So small cell is a type of lung cancer that think about 1 in 10 patients with lung cancer are diagnosed with small cell. That constitutes about 30,000 patients every year. It's within the spectrum of neuroendocrine cancers, and most patients present with metastatic disease. The most important risk factor is having a strong smoking history, although as we know, and it is not universal, and there's patients that are never smokers who develop this, and this is particularly well described in Asia, particularly in China. We know that this is a very aggressive disease, and if you talk to any oncologist, they will tell you the war stories of patients that develop metastatic disease and die within a few weeks of being diagnosed. That is it's again a very aggressive disease. It has one important characteristic, which is that it responds very well to chemotherapy. So initially, when you are first diagnosed a patient and you give chemotherapy, a majority of the disease is chemotherapy sensitive. So you have a very good shrinkage of the disease when you first treat it. However, unfortunately, the disease will acquire resistance to chemotherapy, and invariably we grow again. And when you try to shrink it again with chemotherapy, and in contrast to initially, the treatment is a lot of the cancer is very chemotherapy resistant. There has been a lot of new developments in the past decade, and we are making some grounds, and we're very hopeful that that new treatments are making this disease easier to treat, and are having some success, even with patients even having long-term survival, although unfortunately it is a minority of patients. I said this was within the spectrum of neuroendocrine cancers. Neuroendocrine cancers are cancers that obviously appear within the neuroendocrine cells, and there's neuroendocrine cells all over the body from your lungs to your bladder to your prostate to your bowels. When the disease is very slow growing, and characterize that as very slow growing. The cancer doesn't have a lot of mitosis. That is meant to be a cancer that is not rapidly growing. It's called a carcinoid. Okay, and this is a misnomer because it's a type of cancer. The better name is a well-differentiated carcinoma. I'm sorry, well-differentiated neuroendocrine cancer. In contrast, when you have a very aggressive cancer that has a lot of mitosis and a very high proliferative index, we call that a poorly differentiated neuroendocrine carcinoma. And that is what small cell is, a poorly differentiated neuroendocrine carcinoma. The typical presentation of a patient is that of cough, shortness of breath, weight loss, decreased energy. What we see every week is a patient that comes in, has been coughing for a while, regularly goes to their primary care provider or urgent care. They get an X-ray and they believe that this is a pneumonia because it's what it looks like on X-ray. They treat it with antibiotics as you would a pneumonia with little improvement. And after that, patients get more imaging studies in the form of CT scans that typically show a mass of extensive mediastinal lymph nodes. That's the most common presentation. By far not the unique one, but is the most common presentation. The best way to establish a diagnosis is with a biopsy. A biopsy of one of the organs that is affected by the cancer. If the patient has metastatic disease, it may be a liver biopsy. If a patient has a lymph node, for example, supraclavicular lymph node, it's a biopsy of the lymph node. Many times it's through a bronchoscopy to go down their throat and down their airway to get a piece of a lymph node or the primary disease site. They take a little bit, that is sent to a pathologist who is able to diagnose this. Once we know, what I tell patients when they come in my clinic, I say the most important thing when I see a patient with lung cancer is to know how far advanced this is, to do staging. The typical staging includes a CT scan of the chest, abdomen, and pelvis, a PET scan if needed, and I mentioned if needed because this is an important study to document if there's metastatic disease. But if a CT scan of the chest and the pelvis already documented the metastatic disease, a PET is not necessary. Sometimes we do a bone scan, especially if PET is not available for whatever reason. Sometimes it's logistically. The PET scan sometimes can take a week or two to get that, so we do a bone scan. It's very important also to establish if there's disease in the brain, because we know that a percentage of patients that present with metastatic disease or even with early stage disease can have disease in the brain. The best way to establish that is with a brain MRI, but sometimes we do a CT scan with contrast if there's contraindications to MRIs or if it's logistically impossible. We also need to do a complete blood count in a comprehensive metabolic panel that includes a liver function test. And that's how we do the staging. The official way to do the staging is follow that of how we stage many tumors, which is the TNM staging, which takes into account the size of the tumor. That's what the T stands for, the number of lymph nodes and location of the lymph nodes that are involved, and whether the patient has or does not have evidence of metastatic disease. That is the academic way, let's call it that way, to stage a patient. But traditionally, we just divide cases between limited and extensive disease. This comes from trials that were done back in the 1900s, I'm going to say, in 1980s, 1990s, where these were studies that were led, I believe, by the VA, where people put together and they said, well, if we can treat all of the disease within one radiation field, we'll call that limited stage. If there is more that can be treated with one radiation field, we call extensive stage. And that has been traditionally how we stage patients. This is sometimes very straightforward. Let me see if I have a slide here. Yes. So sometimes that is very straightforward. For example, too far. For example, this patient, you can very easily call it limited stage disease because you can all fit that into the radiation field. This is a PET scan. What lights up is where the cancer is. This is the brain. This are the kidneys. These are the ureters and bladder. So the cancer is here. You can easily call that a limited stage. However, in contrast, this patient has extensive stage disease where all this black dots are disease. So that patient clearly has metastatic disease. Sometimes, however, is very through the eye of the beholder, because what one radiation doctor could call a limited stage, another doctor said, no, that is very extensive radiation. I think that is extensive stage disease. And that goes to tell you why it's important to discuss treatment proposals in a multidisciplinary setting that includes medical oncologists, radiation oncologists, and sometimes surgeons. Surgery is a possibility for patients with limited stage disease when they present without evidence of metastatic, or I'm sorry, without evidence of mediastinal disease, that is disease in the center part of the chest. Those patients can be treated with surgery as well, but unfortunately, that is a very rare scenario because, again, like I said before, most patients present with extensive stage, I'm sorry, with advanced disease. However, we do see one or two patients a year that can be treated with surgery, in which case surgery goes first, and then adjuvant chemotherapy goes later. We know that in non-small cell lung cancer, genotyping has dramatically changed the treatment paradigm, and we have targeted therapy that has improved the quality of life and length of life of patients affected by non-small cell lung cancer. Unfortunately, in small cell lung cancer, we have not identified a driver mutation that we can treat. However, it can be helpful in some cases. Some patients have an epidermal growth factor receptor as a mutation in the first. This is very rare, but can happen. The first presentation is with small cell disease. We know that EGFR in non-small cell lung cancer can transform into small cell, and again, it's been described that it can happen in a handful of cases. When a patient presents with small cell lung cancer, is not the typical, or what you assume is that it doesn't have the a very strong smoking history. That's when we do genotyping. Sometimes also, like I said before, this is within the spectrum of neuroendocrine cancers, and sometimes genotyping and looking for the most typical abnormalities called P53 and RB1 abnormalities is useful to establish if this is going to behave like a small cell when there's doubt by the pathologist. Once diagnosis is complete and one staging is complete, so once you have the treatment, I'm sorry, once you have the biopsy, again, this is a very aggressive disease, so we typically want to start with relative urgency. This is a disease that sometimes once we have all the staging, we say, you know what, we can start, it's better to start treatment in the hospital because we, again, need to start within a week or two. And sometimes that admitting the patient to the hospital is the most efficient way. Again, sometimes patients are very symptomatic, and it's not unusual for this patients to present with shortness of breath or pneumonias that need to be that these patients need to be hospitalized. If you talk to oncologists that treat this, about 20% of patients that are diagnosed initially present in the hospital because they're very sick with this. For patients with limited stage disease, the mainstay of treatment is chemotherapy and radiation. The radiation can take a little bit to be planned, 1 to 2 weeks, and sometimes chemotherapy is typically started because that can be easily done. So we start 1 or 2 cycles before the radiation. For limited stage disease, chemotherapy, with limited stage disease, 4 cycles of chemotherapy done alongside the radiation is the standard. The typical regimens are cisplatin or carboplatin and etoposide. There's a lot of debate in the field whether radiation twice a day versus once a day radiation is better, and that's something that is currently being investigated. And you talk to radiation oncologists, you put them in a room, they're going to fight to each other as to which one is better. Very recently, as of the summer of 2024, a clinical trial established that the addition of a PDL1 agent, durvalumab, after radiation improves survival, and this has become the current standard of care for these patients. So once you get finished with the chemotherapy radiation, you do durvalumab, and the studies continue durvalumab for up to 2 years. I will not be an oncologist if I not show you Kaplan-Meier curves. What these Kaplan-Meier curves this is the publication that got this approved. What you see here is a curve that clearly showed that patients with that were treated with durvalumab had a better overall survival compared to those patients treated with placebo, and that's why it's become the standard of care. Something that I haven't talked to about is that the patients with limited stage disease, the hope is for a long-term disease-free survival, a long-term of disease control. In contrast, extensive stage is not a curative outcome. Patients with extensive stage disease, the purpose of treatment is help patients live longer and live better. But we know that unfortunately, patients with metastatic or extensive stage disease, the disease will acquire resistance, and the majority of patients will die from their disease. I was very careful not to use the word cure in small cell and limited stage, but that's what we hope to achieve in some patients, although unfortunately it's not in the majority of patients because this is a very aggressive disease. When the extensive stage, there also comes the need to start treatment with relative urgency. So again, we on occasion admit the patient to the hospital to start treatment within a day or two. Starting treatment as an outpatient sometimes can be logistically challenging. I'm lucky to work in a very big cancer center that we can get a patient to be treated within a day or two, and we try to treat patients as an outpatient. Typical treatment for extensive stage disease is carboplatin and etoposide as a chemotherapy backbone with either durvalumab or atezolizumab. These two immunotherapy agents have been shown to improve survival. A little word about immunotherapy. The idea is that we all have cancer cells that are being produced. That's the hypothesis. And in the majority of cases, you have T cells, which are the effector cells of the immune system. I call them the police cells that are running around looking for cancer cells. And when they find them, they kill them. But this immune system is very constrained. So they ask for different checkpoints they ask the cell to ask for a checkpoint. I call this to patients, they ask for a secret signal. So if the cell returns that secret signal, the T cell goes away. And tumor cells take advantage of that and can kind of overwhelm the T cell with that secret signal. So they present the secret signal, the T cell goes away, and the tumor cell continues to proliferate and fools the immune system. What immune checkpoint inhibitors do, they're either anti-PD-L1 or anti-PDA1, and they block that secret signal so that when the T cell recognizes the tumor cell cannot evade the T cell, and therefore is killed. And that's what immunotherapy with checkpoint inhibitor is in lung cancer. Again, another Kaplan-Meier curve. These are the two clinical trials that got this treatment approved. This is atezolizumab. As you can see here, atezolizumab was able to improve overall survival and compared to chemotherapy alone, and became the standard of care. And a few years ago, atezolizumab was the first where this was demonstrated. A few years later, durvalumab data was presented. These agents are very similar to each other. Those clinical trials were very similar to each other, and they were very much mirrors of each other in terms of the outcome, showing that that immunotherapy was active in this situation. In patients with extensive stage disease, we tend to give 4 cycles of chemotherapy. After that, we stop. A few years ago, the standard of care was to administer radiation to the brain at that point, because we knew that that chemotherapy does not work as effectively when there's a disease in the brain, and there was a typical sign of failure. And what I mean by that is that the patients would have a very good response in the body, but then a few months later, the disease will appear within the brain. So we treat it with something called prophylactic cranial radiation. However, recently, investigators in Japan did a clinical trial with a modern MRI to establish if prophylactic cranial radiation should be the standard of care. And that clinical trial showed that in patients with extensive stage disease, prophylactic cranial radiation did not improve overall survival. So therefore, an extensive stage disease is not the standard of care anymore. In limited stage disease, this is still a controversial area, and there are clinical trials that are being done that is asking that question, whether that is needed in patients. Something that, as medical oncologists, as our cancer providers, we look at is something that we deem performance status. That is, how well is the patient is doing. There's different scales that we use. One is an ECOG performance status. Another one is called Karnofsky performance status. And there are different scales that tell us how a patient is doing. ECOG is easy to remember. ECOG of 0 is you're doing very well, you're doing all the activities of daily living, you have an ECOG of 0. ECOG of 1 is you have symptoms from the disease, but you're still doing well, you're still active. ECOG of 2 is you have more symptoms from the disease, but you're still up and about more than 50% of the time. ECOG of 3 is up and about less than 50% of the time. ECOG of 4 is you're basically bedbound and you're no longer active because of symptoms of the disease. So this is something that we use a lot to establish when to give treatment, because we know that a patient with a performance status of 3 or 4 really is not going to benefit from chemotherapy in many cases. In many cases, what we do to help those patients live better and live longer is what we call best supportive care, meaning making sure that their symptoms are as controlled as much as possible. Again, I've said this a bunch of times, but it's very important to know that in patients with metastatic disease, the goal of treatment is to help patients live longer and live better, because unfortunately, we're not able to cure the disease. Although some patients do have long-term survival, and I'm lucky enough to have a few patients in my clinic that were presented with extensive stage years ago, but for some reason the immunotherapy was able to really activate the immune system, and they're free, or the disease has not progressed in a number of years. This is unfortunately a very small minority of patients, probably about 10% of cases. Again, in the majority of patients, the cancer will start growing again with extensive stage disease, or unfortunately with limited stage disease, the cancer will come back. In the majority of patients, this happens between 3 to 7 months after starting treatment. Like I said at the beginning, once the disease comes back, it loses that characteristic that it shrinks with chemotherapy. We do have second-line chemotherapy that we can use in those situations, What type of treatment we choose depends on the time it took to become resistant, what other comorbidities the patient has, what other illness the patient has, their performance status, which is very important. There's a lot of different factors. Aside from chemotherapy, there's one agent that most of us are very excited, and this is a type of immunotherapy called tarlatamab, which we call as a T-cell engager. This was approved in early summer of 2024. I'm going to give you a primer of what a T-cell engager is. This is a T-cell engager that happens to be an antibody. It grabs on one end a tumor-associated antigen, and another end it grabs in a protein that expresses in T cells and kind of brings them together. There's a protein in small cell lung cancer called DLL3 that is present in the majority of patients. So that is the the majority of cancer cells. That's the tumor-associated antigen that it grabs. It grabs the T cell. On the other hand, it kind of brings them together. And that has recently shown to be a way of treating this cancer. This is called a spider plot. This is an early stage, an early report of a phase 1 study of this agent. What a spider plot is shrinkage of tumor in different patients. So every line is a patient. This is our patients that have progressed. Their cancer has gotten worse despite chemotherapy. And what you see here is that there was tumor shrinkage seen in 72% of patients. When we do clinical trials, an important number is 30% reduction. If there's 30% reduction, we consider it a partial response. And 40% of patients treated with tarlatamab achieved a partial response with what was long lasting. And what I mean by that is for many weeks. Again, this is a very aggressive disease that we still measure in weeks when the disease is resistant. And again, there was an important number of patients that achieve a response to this agent. The problem with this agent is that it causes something called cytokine release syndrome, or CRS, which is what happens is the T cells get activated. They kill the tumor cells by liberating a bunch of cytokines, and those cytokines can go into the bloodstream and create a lot of problems with inflammation and cell destruction. We grade that by 1 to 4. 1 is just a fever, constitutional symptoms just as arthralgias or joint aches. Grade 2 is when those patients have hypotension that responds to fluids, or they need supplemental oxygen. Grade 3 is when it's more than that. The patient needs to be treated in the intensive care unit. And grade 4 is when they even more sick and they require mechanical ventilation. That is the main side effect of this agent, tarlatamab. And for this reason, this has been studied. This has been administered typically in a hospital to watch for the development of this. This agent, tarlatamab, is being studied in a different setting. It's being incorporated in earlier stage at the time of diagnosis or after chemotherapy. Is being studied in other ways of administration, such as subcutaneously. This tarlatamab is a T-cell engager. There are 2 other companies that are also doing their own T-cell engagers, and preliminary data shows them to be likely as effective as tarlatamab. So the future is bright in a way that we are finding novel treatments that are likely to change the outcome for those patients suffering from this terrible disease. Because of the new agents, there's many questions as how do we incorporate these in early stage settings? Who are those patients that have long-term responses, and can we know from early on who are those patients, and even who are those patients that do well with immunotherapy alone? Aside from the other T-cell engagers, there are other treatments like antibody drug conjugates, specifically those directed against B7-H3, and DLL3 that are for which they are undergoing clinical trials. So although this is a terrible disease, clinical trials, the ability to be enrolling a clinical trial of novel agents is something that we always encourage, because that's how we move the needle forward. And I believe that with that, that's my end of slides, and I'll give it to Katie to talk about it.
Okay. Hi, as you can see up there, my name is Katie Johnson, and I am a clinical nurse coordinator working in the thoracic head and neck department here at Fred Hutch with Dr. Santana. We work closely and have a lot of the same patients. I'm really happy to be here today. I'm happy to be kind of talking with you. Dr. Santana talked a lot about the disease and the staging and the treatment. And what I'm going to be talking about is a little bit different in terms of really looking at some of the side effects of both the disease and the treatment. And then how do we manage those side effects? How do you manage the symptoms, whether they're coming directly from the small cell cancer or from the treatments that Dr. Santana discussed? And then also, one thing I just want to say is just really trying to express how important it is to both advocate for yourself, tell your team and your friends and your family that are on this journey with you what you're experiencing, because oftentimes there are treatments for these symptoms, whether they are physical symptoms or psychosocial and kind of mental health symptoms related with small cell lung cancer. So often, what Dr. Santana just talked with you about is what he shares with our patients in visits. And then I kind of come in right after Dr. Santana talks, and I talk a lot about the other sides of this diagnosis. So what does the diagnosis of small cell lung cancer mean for your life? So for example, I noticed when Tanya was speaking about the where some of the NCCN cancer centers are, Fred Hutch is up in a corner by itself. And oftentimes if people are going to be receiving treatment, sometimes they have to receive treatment for small cell lung cancer outside of their community. So part of that is, where are you going to live? Do you happen to have family in the area that are going to let you get treated at the cancer center of your choosing if you can't do that, near your home? Another thing is just, what are the financial resources available? So if you live far away from a cancer center, even out of state, like a lot of the patients we work with do, what are the resources that are going to allow you to, drive or fly to that center? How are you going to, provide food, and, how are you going to get your rent paid for if you're undergoing treatment and can't work? And so that kind of goes into insurance. What kind of insurance coverage exists for you? Are there other options? Where will your insurance suggest that you're treated based on your coverage? How do you take leave? Sometimes people are like, do I just need to send an email to my provider, my boss? And what do you do in terms of not just getting to treatment, not just undergoing treatment, but living through small cell lung cancer and the treatment if that's what you choose? And those are all things that your nursing team and the team at your treatment center can help you with. These are things that often, I know, at NCCN centers and a lot of the other centers that we work with in kind of in our region, there are built-in support systems to help you work through these challenges. And your nurse, like me, is here to really help you work through these things as you're also working through figuring out what the steps of treating your cancer is. Other things that other questions that patients have are, how do I know if this is working? What if, like Dr. Santana said, often with small cell, initially it looks like initially it does respond to, your cancer will respond to chemotherapy and immunotherapy, but then how do we know if it continues to work? How do I manage the side effects? So this is another thing where both the cancer and the treatment can cause pretty significant side effects. And what do you do to manage those? And then another thing to consider is just, oftentimes you're coming to this diagnosis after sometimes a long period of feeling really crappy and really tired. And it can be a real heavy lift just to try to get all these pieces in play. And again, that's where I really want to advocate for you to make use of your support system and your nurses and your social workers and your providers, your doctors and the nurse practitioners and PAs that are here. We are on your team, and our job is to help take some of this burden. And then the last thing, and I'll talk more about this later, is as Dr. Santana said, one of the things that can come often with small cell lung cancer versus other kinds of cancers is guilt, because often this does impact patients with a heavy smoking history. And that can change the way that you in particular feel about the cancer. And sometimes it can change the way that you manage it. And I really want to kind of talk a little bit about, guilt can be a good thing if it is motivating you to get treatment, but if it is stopping you from responding or helping or getting help, then it's not healthy. And that's when I want you to reach out to your support system and your care team, including, again, your nurses. So I'm going to go ahead and move on to some of the side effects. So what I'm going to talk about here are just some of the physical side effects that we all hear about and know about with cancer. So you will go through these with your team, but radiation can cause rashes. As Dr. Santana mentioned, the radiation can be targeted at the cancer specifically to shrink it. It can also be if you have disease in other places, it can help, and that's causing pain, particularly like in bones. You can get rashes over the sites of the radiation field. You can also get sores in your gum, in your mouth, in your throat, again, based on where that radiation field is when they're treating you. And a loss of appetite due to, again, the radiation field sometimes going through your mouth and your tongue. This is more likely in terms of the sores in the gum and the mouth and the throat and loss of appetite when the radiation field is kind of from here up rather than here down. And then fatigue. When we're killing cancer cells by directly targeting those cells with radiation, you're killing often a lot of cells at once, and that can cause just a really strong sense of fatigue where it's even very difficult just to get up and do your normal things after radiation. With chemotherapy, chemotherapy is often targeting cells that turn over quickly in the body or the cells that grow quickly, like cancer cells. So when you're getting a systemic treatment like chemotherapy, not only are you killing the cells that we want to kill, like the small cell cancer itself, but also you tend to have effects in other parts of the body. So you can get effects in your GI system, both from that cell turnover and also the chemotherapy itself. And you can get a lot of nausea. You can get tingling, especially with the platinums, like cisplatin and carboplatin that Dr. Santana mentioned. It can cause tingling, ringing in your ears, and a loss of interest in eating. And again, that loss of interest in eating can lead to weight loss. And that's just because when we're using this chemotherapy, you're getting that cell turnover in your tongue where your taste buds are. Things don't taste the same. But the good news is with all of these side effects, we do have ways to manage it. And again, just pain related to sometimes joint pain, pain at the site of the cancer. Immunotherapy causes rashes, shortness of breath, diarrhea. These are related to we're amping up your immune system to fight that small cell cancer. But when your immune system is amped up, sometimes it can overreact and it can affect your skin, so you get some rashes. It can affect the lungs themselves, and you can get some inflammation in the lungs, and it can affect your colon and cause diarrhea. Again, what I want to say about all of these side effects is that the goal is not to suffer through them. The goal is to tell your team you're experiencing these. We have ways to, we can give you medicine to help with the nausea and vomiting. If you find that the medicine your provider and your team gave you isn't working, let them know as soon as possible. There's really a whole cadre of medicines that can help here. With the anemia and neutropenia, those are things that your provider team and your care team at your clinic will measure. But if you're feeling like really short of breath or you're losing weight just because you've lost interest in eating, those are things, again, let us know. let us know how you're feeling. It's important to kind of try to maintain your weight, to try to manage that nausea and vomiting so that you can continue to be strong and fight this cancer with treatment. And same with immunotherapy and radiation. Just let your team know what you are experiencing when you are experiencing it. And don't think there's any symptom that's too small. Oftentimes we know that if we can know about a symptom early, we can manage that symptom earlier, and you have better management than if you wait until, boy, Katie, I wanted to let you know about my nausea and the vomiting, but I really thought I could manage it. And then, 3 days later, you're completely miserable. You haven't been able to eat or drink. And we tell you, boy, you need to come in to get some fluid so we can help you stay as healthy as you can be. Tell us early, tell your care team early so we can help you. And I want to say this is really the same with the side effects of the kind of emotional and social side effects of small cell cancer. So in particular, when you're diagnosed with a cancer, I don't have to tell you guys that these are some of the side effects that we experience. And really all of this comes down to sort of initially it's a grief. There's a loss of the way that you had lived your life previously, and now you're going to have to find a new way of moving through this disease and this diagnosis and this, I like calling it a condition because you're going to be living with it. Especially in the extensive stage small cell lung cancer, this is something that you're going to be living with, and these are normal things to feel. One thing I highlighted earlier is that there can be a lot of guilt, especially if the small cell lung cancer is related to an extensive smoking history. Anxiety and depression, there's anxiety around initially, what stage do I have? How is this going to be treated? Then there's anxiety around, oh my gosh, I have to go in for this scan. What is the scan going to show? Is it going to be good? Is it going to be bad? What is my provider going to tell me? And then you're also just, you're changing the way that you look at yourself, the way that you look at yourself with your family and with your friends and with your coworkers. And that can be really difficult. But again, these are things that are expected. There are medications that can really help manage some of that anxiety and depression that work really well. Sometimes you have to try a couple different, just like when you have blood pressure problems, you have to try a couple different medications. But this is where that close communication with your team and with the people around you in your life, your support system, can be really helpful. Oftentimes, one of the things that I find as a nurse, and I know Dr. Santana does too, is we find that patients often do come to this sense of resilience. You find that you can manage more than you thought you can. And you also find something that is not common in our society is giving yourself grace. We're taught we're going to fight. This is a battle. If I can't handle these side effects, then it's because, of an inherent weakness. And that is not true. And learning to give yourself grace, learning to accept your side effects, accept your situation, and accept help is really key and can be really a beautiful thing that will help you find learning, like growth through this. And again, though, the key is just working with your support system to do so. And again, I know I've already kind of discussed this, but your personal team are the people that are obviously with you, your caregivers that live with you in the home or that come in to provide care, your family members, your friends, your spiritual leaders, whatever, your priests or rabbis or imams or whatever that looks like for you. And the other thing I want to mention is because of some of the isolating feelings related to this diagnosis, a lot of people find help with others that are going through this disease. So online care support and support groups can be really helpful. And then your clinical team is your nurses, your providers, dietitians that can help you often through telehealth visits. If you are having those taste changes and aren't hungry, the pharmacists that work here and work, even in your local pharmacies that can talk to you about side effects or kind of talk with you about other things that can help. Our social workers that work closely with the nursing and provider team at almost every cancer center to find help with some of those things we discussed on the first slide. So, what are there grants available for travel? Is there any housing that the cancer center knows of nearby that is, at a discount? What financial resources are available if I don't have access to insurance at the cancer center itself? And then again, our spiritual health team here is really wonderful. They are non-denominational, but again, just kind of open up this sense of this is larger than just the diagnosis. It changes the way you think, and there are people at the ready who want to help you if that's something that you want to access to move through this condition. I also want to give a shout out in terms of the clinical team. A lot of places also have palliative care, and palliative care is something that is available to patients from the moment of diagnosis. And it's another team that works with your clinical team to provide help through side effects and also look at kind of the larger sense of what are your goals of treatment? What do you want to do? I also just want to say palliative care is not hospice. It is really designed to help support people through the disease journey. And it's awesome. We know that patients who engage with palliative care often have a better quality of life, which especially in our extensive stage small cell lung cancer patients is really important. We want you to live the life that you want to live. It's going to look different, but it's important that you're living the life you want to live, and palliative care and your clinical team and your support systems are the way to do that. These are just some daily care tips. The number one tip, there's a lot on here in terms of managing your condition, managing your medications. But the one thing I want to say is that you have the disease of cancer, but you are not cancer. It's really important that you find at least one thing every day that gives you joy that is unrelated to your cancer diagnosis, your treatment, or anything you feel about it. So if that is playing with your dog or playing with your grandchildren or writing letters to family just to see how they're doing, actual letters, email's great too, but it's always nice to get real letters. That's really important. And it's important because sometimes this can be this is a huge lift in terms of disease and diagnosis and treatment. And it's important to remember why you're doing it. And it's because you're you and you're valuable and you deserve to remember who you are. If you have questions about any of these other things, we can definitely talk about it. I do want to say medication logs and, getting just like a notebook like this and then making tabs for the different providers that you visit can be helpful, so you can refer to that. And then you can also have a space for writing questions down. Obviously, I hope it's obvious. If you forget questions, you can always reach out to your nursing team and we can get the answers from the providers for you if you forget while you're in the middle of a visit. And then again, just enjoy the day, be with your friends and family, make time to laugh, make time to watch silly things, whether that's on YouTube or, some kind of a TV show that you like, or books. If, get some books that help you remind and connect with who you are. And then my final thought is just, this is a journey. And like any journey, you have to go through darkness to get to a place of light and of grace and resilience. And we're here to help you do that. So while you're on this journey, just remember there is a sunrise, and this is a sunrise from my backyard. There is a sunrise and there is hope, and we're here to help you with that through this incredibly difficult disease. And I will now go ahead and mute myself, and it is time for Charles to speak. Thank you very much.
Good afternoon. My name is Charles Forsham. As I told you, I'm a patient advocate. It's primarily based on my background. I feel like I'm fairly well qualified to speak on the cancer journey. I have a great deal of about 16 years experience with cancer. I have had multiple cancers, all primary cancers. I've had prostate, lung, kidney, melanoma in the neck. And I currently have, I'm not sure if it's malignant or not, a neuroendocrine tumor in my pancreas that's being monitored. Hopefully that'll turn out to be a non-malignant tumor, but with my history, I don't take any chances. all my cancers have been stage 1. I've been very lucky uh, in that regard, primarily because of the constant monitoring. They've been found because I had the prostate cancer. On subsequent tests, I found the lung cancer. Subsequent monitoring, I found the kidney cancer, and so forth and so on. So it's very important to have this constant care. But as I said, I feel like I'm fairly well qualified to talk about the cancer journey. And a lot of what I will be talking about is somewhat overlapping with Katie. Now, as a lung cancer patient advocate, um, I'm a member of several boards of cancer advocacy groups. I'm on a DoD panel for lung cancer and on protocol review committee at UT Southwestern. So I have a lot of intermixing or contact with patients as part of my advocacy group. What I wanted to talk about, as I said before, somewhat overlaps with what Katie said, is how to handle the diagnosis of cancer and the continuing care. When you're first diagnosed with cancer, lung cancer, as I was devastated. Your normal reaction is to have doom and gloom and basically think because of the history of lung cancer, you're going to die. And then you immediately go to the internet and you start reading about lung cancer, and you're further convinced that you're going to die. That is the biggest mistake I think cancer patients make, is doing this independent research on the internet of sources that you don't know are reliable, excuse me, or sources that are old. What you need to do is to rely on your care team. And that's why I said in this first slide, know your care team and the resources available to you. You first go to your care team and learn who your care team is and what is available to you. As Katie said, your care team not only involves your oncologist, it involves the social worker, the dietitian, the insurance people, and most important, in my view, is the nurse navigator, who will answer many of your questions and guide you as you begin this journey with cancer. What you need to do is always maintain hope. And by getting proper information, you know what the treatment is out there, what the course of your care is going to be, and how to deal with this as you come along. In the short time I have today, I'm going to go through many steps that I have found that are important in evaluating cancer. As I said, the first one is to know your care team and the resources available to you. Second is to be involved with that care team. Don't ever feel like you're just a piece of meat out there being treated. You're part of this journey, the most important part. You need to be educated. You need to ask questions all along the way and know what is happening to you and what the prospects are down the road. Always be free and open to talk to your care team. Again, as I said before, sources of information and education. And we're going to get to a list of that at the end of this presentation. But you need reliable sources. Many of the internet sources are old, outdated, as I said before. You need to know what are proper, up-to-date sources and accurate sources and reliable sources. You get those through your nurse navigator can give you that information. There are many lung cancer organizations out there, some of which I've been involved in, like the Go-To Lung Cancer Foundation, that have a lot of information available to you. There's also on the internet, you do have sources that are good, but you need to make sure they're reliable. As I said, your nurse navigator can help you with that. Another thing, I'm going to skip over the clinical trials at this point and get back to that a little bit later. I want to talk to you about something Katie also mentioned, and that's the depression that you go through. I call it scanxiety. As you go through your treatment, you'll have multiple scans throughout the course of the treatment. And after treatment, you get scans on a regular basis, such that I have, because of my multiple cancers, I have CTs, MRIs, X-rays multiple times a year. In order to survive the lung cancer and other cancers that I've had, I've developed the ability to kind of put my cancers aside and try not to think about them as much as I go crazy if I was thinking about cancer constantly. But that comes home every time I have a scan scheduled. I can put it aside until I'm a week or two before the scan. Then I start thinking about and worrying about the scans. And then after the scans, I'm worried about it until I get the results of the scans. That's what I call scanxiety. You're going to have to face it and you're going to have to deal with it. It will happen. It's real. And it's justified because you've had cancer. Once you've had cancer, it's always there. You always have the threat of it coming back, or in my case, other cancers. But you learn to deal with it. But you need to realize what's going to happen. Your family's going to notice it because all of a sudden you get quiet, you get depressed, you pull into your shell a little bit. They need to be made aware of it as well, and know that that is a reality, something you'll have to face. And here now, family relationships that I have listed here, family involvement and family care. This is a family ordeal that you'll be going through. Your family needs support as well as you do. Your family needs to be educated as you do. They need to understand what's going on. They will be able to cope with the cancer and help you through this ordeal if they're as educated as you are. Both you and the family need to know the availability of these resources and seek help where they need it. But I'm telling you, education, in my view, is key to being able to cope with this disease and know where you're going with it. Now, next, and most important, I think, are clinical trials in your cancer journey. Clinical trials are so important in the constant advancement of treatment of lung cancer and every other cancer. They are the only way that we develop these cures and proceed with treatment of cancer. There are 5 basic types of clinical trial. The diagnostic trial, which is just develop, as it says, develop better tests and procedures. Treatment trials, there are treatments for cancer. Prevention trials, ways that you prevent cancer. Screening trials, new ways of screening for cancer, and quality of life, supportive care, and palliative care trial. Of course, as a cancer patient, you're most interested in treatment trials and quality of life and supportive palliative care trials. Many people have their only hope in treatment of cancer is possible new cures, new treatments, ways of handling side effects and that sort of thing. And that's why clinical trials are so important. But the phases of clinical trials, there are 4 phases. One, the first phase, which tests the safety of a new treatment and determines the best way to administer it, it's carried out after animal research is done and is deemed ready for humans. The phase 2 trials determine if new treatment has an effect on certain cancers. It's carried out after the treatment is deemed safe. The phase 3 of a trial compares the new treatment and the current standard treatment. This is where you normally get into the randomized studies and control group and a test group. Control group will receive a placebo and standard of care treatment, while the test group receives the new drug. Phase 4 is the much larger group of patients are studied. Additional information is gathered about the effectiveness, side effects, and safety that can be gathered from a much larger group. What's important in evaluating clinical trials and whether or not the ones available to you is normally all spelled out in an informed consent that's given to you. As part of my cancer protocol review committee duties, I'll review the informed consents from the patient advocate standpoint for the patient and try to make sure that a patient can understand them. These questions that I have here should be answered in your informed consent, but they're all important, and you need to make sure you understand and have answers to these. So all informed consents vary from one to the other, and some are very good and detailed and some aren't. But you need to make sure you understand the answers to these questions. What's the goal of the clinical trial? Has the treatment been studied before? What phase is it? You may come into a clinical trial at a phase 1, a phase 2, a phase 3, or a phase 4. Where is the trial? Who oversees my care during the clinical trial? All right, is it your doctor or is it a study doctor in an institution? Where's the clinical trial going to be conducted? Is it going to be conducted at a cancer center? Is it going to be conducted locally? How does your care change during the course of the clinical trial? Are you going to stop your current treatment and start a new treatment? What are the risks and benefits of the trial? What are the side effects? What are the knowns and unknowns? The side effects can be very compelling. During the early phases, one of the things that they do in the phase 1 is to see what side effects there are. Some side effects are unknown. Can you tolerate the side effects? How are they going to be handled? Will a clinical trial cost me anything? Most of the trials that I've seen are no cost to the patient. If other costs may be covered by insurance, you need to know that. Some trials you're paid or reimbursed travel expenses. You need to know what financial burden, how far you're going to have to travel. Sometimes these trials require inpatient hospitalization. How long? How often? You need to know those answers. Can I leave the trial at any time? If I leave the trial, what happens? Can I go back to my standardized treatment? Or has that been ruled out? What happens if the clinical trial is ended suddenly? And sometimes they are. Will I be able to get treatment if this treatment doesn't exist? Like I said, does this treatment rule out other treatments? And will I know the results of the trials? And who will tell me these results? All these are very important questions that need to be answered when you enter into a clinical trial. But clinical trials are important. Some patients live from one trial to the next. Sometimes the standard normal treatments are not available or not effective. And the only hope that the patient has is a clinical trial and finding those clinical trials. And here again, that comes down to the information. Where do I find out about clinical trials? Your care team, patient advocacy groups again. Use a trusted source. NCCN has clinical trial information. Your nurse navigator will help you with those. It's very important to have a handle on clinical trials and know what's available out there to you, because it could be the lifeline that you need. Now, as I said, other sources of information that I think are good are listed here under resources, cancer types, the Medline, the organizations like Go-To for Lung Cancer organizations, livelung.org, LCF, LungCan, Longevity. All these organizations are out there to help you as a lung cancer patient. Use them, use that information. Don't use the internet. I can't stress that enough to you. Now, let's move on to the questions and answers.
Okay. So we're going to start the Q&A. You can submit your questions in the Q&A box. So we have 2 questions. And so one, This is something we've mentioned before, Dr. Santana Devia. I want to ask about LEMS, the Lambert-Eaton myasthenic syndrome. If you could just tell us a little more about that and what role it plays in small cell lung cancer.
Yes, so that's something that I didn't talk about. Notoriously, small cell lung cancer, yes, can present with autoimmune phenomena. And one of these is the type of the Lambert-Eaton syndrome, sorry, where you basically is a type of myasthenia gravis where you cannot move. The thinking is that there is antibodies that are directed against the cancer, but for reasons that we understand, can also be directed against your immune system. So patients present with weakness that can be very, very severe to the point of paralysis. And the treatment of choice for this is to actually treat the lung cancer. You treat the lung cancer, and occasionally this gets better. Recently, there is medications that can improve this. As an oncologist, I don't have a lot of experience in how to manage this, because what we do when this presents itself is we ask our neurology colleagues to come in and help us manage the Lambert-Eaton component of things. So they know they do plasmapheresis on occasions. They do these other new medications. But again, the mainstay of treatment is treating the cancer. Other autoimmune phenomena that can happen is problems with some hormonal problems. Another thing that is not autoimmune but is very frequent, paraneoplastic syndrome, is low sodium. That is something that can be the main presenter of this disease. Somebody gets not feeling well, gets to their doctor, and they did some blood work, and they have a very low sodium. That is very common in this disease. And then how you treat that is again by treating the cancer.
Okay. And then we had a question about the use of immune modulating drugs in those with autoimmune disorders.
Yes. So that is a something that is a little bit controversial. So immunotherapy, what it does is unleashes your immune system so that it can hopefully recognize and attack the cancer. Like I said in my presentation, the immune system is very constrained and needs a few checkpoints to attack cancer cell. Patients who have autoimmune diseases, such as lupus, rheumatoid arthritis, multiple sclerosis, if you unleash the immune system, that autoimmune condition will likely get worse. If somebody has a relatively low-grade autoimmune disease, for example, I'm going to just throw this as an example. Somebody has rheumatoid arthritis and has a very low version of it, where you have just some joint aches that you treat with ibuprofen or something like that, then you can carry that risk of using immunotherapy that will again make this autoimmune disease worse, but you can control that. In contrast, if you have somebody who has rheumatoid arthritis that is very severe, that is already in immunosuppression, or their quality of life is very affected by the disorder, or that the problem is in your lungs and is pneumonitis, that you are worried that if you unleash the immune system, that will get this disease worse, and there's not a lot of wiggle room, then that is a contraindication. So there's no right or wrong answer as to how to use immunotherapy in autoimmune disorders, and that's something that needs a consultation with your provider. And sometimes this is one of the things where experience matters. So if you're the patient and your oncologist says, I don't want to do this, that's getting a second opinion of a major cancer center that manages a lot of patients with immunotherapy might be worthwhile.
Great, thank you. And has anyone had long-term survival of more than 5 years with limited stage?
Yes. For limited stage, yes, long-term survival with limited stage is not unfrequent. if you look up the Kaplan-Meier curve of the latest clinical trial that used durvalumab, I cannot remember off the top of my head, but overall 5-year overall survival is present in somewhere on 40% of patients. So yes, with limited stage, long-term survival is achievable and is the goal of treatment. In extensive stage, that's different. Extensive stage, 5-year survivals can happen, but are rare.
Okay, thank you. So let's see. I guess I don't see any more questions coming through just yet. So we're getting close to being out of time. So I would just like to ask each of you your final thoughts, whatever they may be, if something that you think is important for a patient or caregiver to know, etc. We'll start with you, Charles. Go ahead.
The key thing is always maintain hope. Use use the resources that are available to you, and know that there are cures and treatments out there. You just have to keep at it and never give up.
Katie, thank you, Charles.
Yeah, I just want to echo Charles. I think that as a patient or a family member, the thing that I want to really emphasize is the importance of advocating for yourself, listening to your body, whatever. If you are feeling something, if something feels different, if you have a question about if a symptom you're having, a medication you're on, even when are your treatments or what do you have coming up, please reach out and ask questions of your team. It is our job and it is truly our honor to work in this field and to be your resource. So please ask questions, ask them frequently, ask them often, so that you have the best information you can as you navigate small cell lung cancer.
I'm going to try to be as brief as possible, but I want to touch on things that both Charles and Katie mentioned. This guilt is very true and very real for specifically for small cell lung cancer, because patients know that maybe they had not smoked, this would have not happened. Well, this is what I hope that most of my patients have is a realization that this is not their fault. Yes, smoking is a risk factor for this, but doesn't mean that it happens to people that smoke. There's plenty of people who are casual smokers or never smokers that get it, and many people who smoke a ton and never get it. So why did it happen to that patient? We don't know. But this is a card you're dealt with. We need to manage them. You need to continue to live your life. Like Katie says, cancer is not your life. You need to maintain hope. Hope comes in many flavors. Some people, so sometimes the hope is that you're cured from this disease. Our Charles has hopefully all his cancer are stage 1, so hopefully he has been cured from this. But there's also hope when the cancer is not curable, that the remaining time that you have, be that days, weeks, months, years, whatever it is spent the best as possible, that you continue to live, that you continue to do what's important for you, you continue to feel the love that your family members and friends have for you, and that is also a very good hope. Sometimes hope is also having a good death. That is also hope for that. So there's always hope, but their hope comes in different flavors. The last thing is clinical trials are very important. Charles said that way, that's how we move the needle forward. Obviously, to participate in a clinical trial, there's clinical trials that are right for you or clinical trials that are not right for you. Some clinical trials will help you a lot. But by participating in a clinical trial, you also are helping other patients, not just only you. You're helping this move the needle forward so we can treat this disease and we learn how to treat this disease. And finally, as Katie said, it is our privilege to be part of your team. we're here from you. This is not a battle that, sorry, I hate the word battle. This is not a journey that you're gonna go be on your own. So reach out to your providers. That's what we're here for. It's our privilege.
Great. Thank you so much. We are out of time for today, and I would like to thank everyone for attending and our presenters. The NCCN Foundation would also like to thank the corporate supporters of this webinar.